Well, once again, I see that my recording app is smushing my slides, but this chapter is going to be talking about fluid balance and chemistry. We're going to be talking about the distribution of water, electrolytes, and the acid-base balance. And first off, we need to understand the concept of fluid compartments. All the fluid in your body can be divided into being in one or two places. Either it's going to be inside the cells or it's going to be outside the cells. So the intracellular compartment is going to basically be cytoplasm, and then we have everything else that's going to be distributed in different portions of what they refer to as the extracellular compartment. So remember, water is going to be basically making up approximately 60% of your body, depending on your age, your gender, etc. And it's actually 99% of all the extracellular fluids. So your body is, you can think of it as a bag of soup. The water is going to be keeping all the electrolytes in solution, keeping it with all the sodium chloride and potassium ions from clumping back together. And it's necessary for maintaining homeostasis. Water is necessary to distribute nutrients and oxygen and to carry carbon dioxide and waste to areas in which it can be eliminated. I'll tell you when you get to numbers that you really need to commit to memory. This is not one. This is just simply an approximation. If you notice that women tend to be a smaller component of water in the body weight, and that's because men tend to have more muscle tissue and women tend to have a higher percentage of fat tissue. And the muscle mass is going to contain more water. So again, this is going to vary with age, as we'll see in just a moment. We actually start out as mostly water. Basically, I've seen somewhere it said that the percentage of water in a newborn is roughly equal to that of an Irish potato. So we gradually dry out as we get older, and you'll actually see that in elderly people. You'll see that their tissues are smaller, they're shrinking, they're losing muscle mass, they're losing height, and one of the reasons for that is that their intervertebral discs are actually drying up. Their hair will become drier, the skin becomes drier, their eyes become drier. So, unfortunately, it sets us up for a lot more susceptibility to severe issues with the elderly patient also. This chapter is a lot about balance, and this is a very simple concept. It's balancing what's going into the body with what's going out. So you can look at fluid balance. Obviously, what you gain in fluids, you're getting by eating or drinking it, and you're losing most of it through the urinary tract, although some through the GI tract and some across the skin and through the respiratory system. Same with the electrolyte balance. You're basically eating or drinking these things, and you're going to be urinating and sweating these things out. So let's look at some of the subdivisions of the extracellular fluid. This composes about 1/3 of the fluid that's in the body all total. And there's two major compartments. Interstitial fluid. This is the fluid that's bathing the cells. It's a tissue fluid. And then the other major component of this is going to be the plasma, the fluid portion of the bloodstream itself. You do have some minor compartments that you need to know. This would include the lymphatic fluid, the cerebrospinal fluid, the synovial fluid in the joints, and then the serous fluids that you'll find, for example, in the thoracic cavity or the peritoneal cavity. And then also, of course, we have a little bit of fluid in our eyeballs known as the aqueous humor. So you're going to find sodium, chloride, bicarb, a lot of other nutrients, some proteins in this fluid compartment. And we'll be discussing the movement of this as we get further into this. The intracellular compartment, again, this is basically the cytosol or cytoplasm, the liquid portion of the cytoplasm. And you're going to find mostly potassium. So if you recall from talking about nerves and muscles, we talked about the ions or the electrolytes inside the cell that set up this transmembrane potential. And we said that the inside of the cell membrane is negative in comparison to the outside of the cell membrane. We also talked about the ions that made this possible. And we said inside the cell you had a lot of potassium and a little bit of sodium. What you'll find in the interstitial fluid is you'll have a small amount of potassium and a lot of sodium. And remember, those are going to be the ions that are exchanged when you have action potentials. So now I know you're going to say, oh, but wait, why is the inside negative when the potassium ion is positive? And that's because you also have a lot of chloride ions, which are negative, but you also have some major proteins inside these cells, and those proteins carry a negative charge. So the overall is going to be negative. In particular, what they're talking about is what is lined up against this cell membrane. In chapter 3, when we discussed the cell, we talked about the cell membrane being a selectively permeable membrane. Remember, we talked about the bilayer phospholipid membrane. And when they say selectively permeable, it chooses what's going to be able to move easily across membrane, what's going to need carriers, and what is going to be excluded. So water can move very freely between the extracellular fluid, the interstitial fluid in other words, into the cytosol, or the intracellular fluid. So you also have millions and billions of the tiny little pumps known as, or not pumps, but pores, openings known as aquaporins, which allow the water to move in even faster. So water can fluctuate between these two compartments as needed. So what we'll be talking about as we get further into this chapter, if something happens that you have a decrease in plasma volume, so you've got an increase in the concentration of the plasma, you'll have fluid that will leave the cell and go into the plasma by osmosis. So the sodium-potassium exchange pumps, these are located in the cell membranes, and those help restore the ion levels. Remember, we talked a little bit about leak channels, which are happening all the time. You've got a constant movement but no net change until you've got an action potential that really opens up these active pumps. Proteins simply are too large to leave through these cells. So you've got intracellular proteins, and then you've got proteins in the plasma. And typically these plasma proteins aren't going to be leaving the blood vessels. If they do, then the lymphatic system will sort of scavenge those and return them through the subclavian veins. Recall from earlier chapters that these protein molecules are what give you the blood colloid osmotic pressure. So we've talked about that many times, and the opposing force to that is the hydrostatic pressure. We also refer to that as basically the blood pressure. So again, what we've talked about is as blood's flowing, you've got the blood pressure producing the hydrostatic pressure. You get down to the capillaries where it's thin enough, and you're going to have water being forced out of the capillaries, and that's going to start concentrating the plasma proteins and the cells, and now you've created an osmotic force to pull it back in. So that's basically what drives the fluid across the capillaries. And what's happening, the purpose of that, is that this fluid that's leaving the capillaries is going to be containing oxygen and nutrients, which will go into the cell, and then the cells are producing waste and carbon dioxide, and that's going to go back into the blood vessels to be eliminated at the levels of the lungs, etc. We've talked about these hormonal systems before, and we need to mention them again. These are going to be things that control fluid movement, and one of the big axis systems is known as the renin-angiotensin system. We discussed that before when in the chapter about the kidneys, and also in the endocrine system. So remember that anything that causes a decrease in the blood pressure is going to cause release of renin by the juxtaglomerular apparatus, and the renin is going to activate a series of steps that is going to be activating angiotensin. And then the angiotensin is going to cause sodium reabsorption in the proximal convoluted tubule. And remember, water follows salt, and so when you resorb the sodium, you're going to be bringing water in there. You also are going to be causing some other physiologic aspects as far as stimulating thirst. You become more sensitive to the taste of salt. And you also stimulate the release of a mineralocorticoid hormone from the adrenal cortex known as aldosterone. So you've also got some other things happening here as far as vasoconstriction, but we're talking more about water movement here. So you've probably never thought about the idea of thirst. It is true that once you are thirsty, you are already dehydrated. The thirst mechanism happens simply by detecting an increase in the osmotic pressure or the osmolarity of plasma. So you've got osmoreceptors located in the hypothalamus that will be detecting when plasma is getting basically too concentrated. And so that's going to cause a decrease in saliva production, so your mouth is kind of dry, you want some water. And also, you actually will become more sensitive to the taste of salt. If you're familiar with the seasoning, the Old Bay seasoning, they actually came up with that in a bar in Maryland, so the story goes, because it would stimulate sales of beer. So the more salty things that somebody ate, and in fact, that's why they have chips and peanuts and everything at a bar, the more salty things you eat, the more you want to drink. So angiotensin also is going to be a trigger to stimulate that thirst center. In addition to being triggered by the angiotensin axis, aldosterone is also going to respond to a falling sodium level. You'll also be released in cases of high potassium levels. So one of the things that a physician will tell you to do if you have high blood pressure is to reduce your sodium intake. And on the market, there is a type of salt substitute called light salt, Lite. And instead of being made of sodium chloride, it's actually made of potassium chloride. And the problem is, what will happen if you've got somebody who uses too much of this? My dad is a good example. He never even bothers tasting his food. He just pulls a salt shaker over and starts dumping it on there. And so he's getting a huge dose of potassium. Again, now the point is, you're trying to reduce your blood pressure. However, think about this. If you have a really high potassium level, that's going to trigger release of aldosterone, which is going to cause you to retain sodium, which is going to cause you to retain water, and that's going to make your blood pressure even higher. So there have been cases of known fatalities from people overdosing on potassium. The last sentence here, salt conservation stimulates water conservation, is simply another way of saying water follows salt. ADH, or antidiuretic hormone, is going to be released from the hypothalamus when the osmoreceptors are picking up concentrated plasma. And one of the big functions here is this going to cause you to produce more concentrated urine. It's going to decrease water loss. And it does that by increasing permeability of the distal convoluted tubules and the collecting ducts. The sympathetic nervous system is also going to play into regulation of fluid balance and blood pressure. Anything that causes low blood pressure is going to stimulate the baroreceptors. You've got those in these little aortic and carotid bodies, which are located in the aortic and carotid sinuses, these little pockets of these blood vessels. And so if blood pressure is low, the sympathetic nervous system is going to cause a vasoconstriction in the afferent arteriole, and that's going to decrease the glomerular filtration rate. That's going to do two things. It's going to decrease the amount of urine you produce, and it's also going to activate that whole series of events that begin with renin. So you'll be going from renin release to angiotensin activation and end with aldosterone secretion. And recall that the hormones that will have the opposite effect will be these sodium losers. Natrium is Latin for sodium, and uresis is to urinate, so natriuretic peptides will trigger the elimination of sodium, which is going to cause the elimination of more water. So atrial and brain natriuretic peptide, remember these are both released by the walls of the right atrium when they're stretched. So these are your sodium losers. So as we've been talking about, there is an equilibrium between the extracellular fluid and the intracellular fluid. So you've got movement out from the hydrostatic pressure, you've got movement back into the blood vessels, or back into the cells rather, by the kilowatt osmotic pressure. And normally there is a net equilibrium, so you don't have a net change, in other words. But remember that when you do a blood test, the only thing you're testing is plasma levels. So you really can't measure on a practical basis the content of electrolytes or solids that are inside the cell. So you're only measuring what's in the ECF. So let's take a look at water balance a little bit closer. Again, the average adult male is going to be about 40 liters of water. And you're going to take in over 2 liters of water a day through what you eat and drink. And you're also going to be making water as a byproduct from all the cell metabolism that's happening in your body at one time. We talked about the electron transport system, we talked about Krebs cycle, etc. And one of the byproducts of those metabolic processes is going to be water. So you're going to lose about 1.5 liters through the kidneys on a daily basis. So here's a breakdown showing input and output, with input being on your left. Again, you're going to make not a large amount, about 10% of your fluid is going to be coming from the byproducts of metabolism. You're going to be drinking, obviously, the most of it. So, and you look on the other side, you'll see that you lose a small amount in feces. You'll lose a small amount in sweat, and you'll lose even more in what they refer to as insensible losses. And this is where you're going to be having water evaporated across your skin and also through your respiratory tract. If you don't think about what's in the respiratory tract, breathe in a mirror and you'll actually see it condense. So you do lose a substantial amount of fluid that way. But remember, about 60% of your fluid loss will be, of course, through the kidneys. Looking at this again on a volume basis, you're looking at, again, a little over 2 liters a day in consumption, and then about 300 cc's, or 250 as the previous slide said, through metabolic production. And then you're going to urinate about 1.5 liters to 2 liters a day, and then you'll see the rest of the description here. You're losing about 1 liter nearly through your skin and your lungs, and of course that's also going to be dependent on your ambient temperature and humidity, as well as your activity level. So let's look at some terms referring to the level of fluid in the body. So the most obvious one that I'm sure you've heard is dehydration. So when you get dehydrated, your water level has decreased, but your electrolyte concentration has not. So in fact, it's going to be increasing. What's going to happen is the osmolality level of the plasma will have increased because the electrolytes are becoming more concentrated. Imagine putting a dish of salt water outdoors in the sun, and the fluid's going to evaporate, but the salt will simply get more and more and more concentrated until it's the only thing left. So water will move from the cytoplasm into the ECF, trying to increase the level of content, the fluid content in the ECF. It's going to try to reach equilibrium. However, eventually it's going to kill the cells. Examples of things that cause the loss of water and dehydration would be diarrhea, vomiting, excess perspiration, or a lack of water consumption. Okay, so my artistic ability is lacking on a good day. Give me a stylus and it gets even worse. But I just wanted to try to walk you through the term dehydration and also the next few terms I'm going to give you. Let's take a look at an erstwhile beaker here, and we're going to put a solution in there, and we're going to make this solution, let's just pull some numbers that will be easy to manipulate here. Let's say this is 10 liters of water and 10 grams of salt. So that's going to be our normal. Now, if we're going to call this dehydration, what's going to happen in this volume is you'll end up losing some water, and so now we might only have 7 liters of water, but we're still going to have the 10 grams of salt. That's not going to change. So that would be your example of dehydration. So in the term hypovolemia, what happens here is you're going to lose part of the water. So let's make that 7 liters of water, but you're going to also be losing a proportional amount of the electrolytes. So now we're going to make that 7 grams of salt. So with hypervolemia, what you're going to see is you're going to have excess water, but you're going to also have excess electrolyte levels. So now we're going to say we're going to have 10 liters of water. I'm sorry, let's make that, go back and make this 12, because my starting point was 10. And then we're also going to have 12 grams of salt. So you've had a proportional increase in both the water and the salt levels. Now on the other, we're going to have an increase in the water level, but we're not going to have an increase in the salt level. So that's going to be called over hydration. So, you know, forgive the chicken scratch here, but I just kind of wanted you to think about dehydration versus overhydration versus hypo and hypervolemia. Now, I'm going to give you those definitions on the next few slides. So here's your definitions for hyper and hypovolemia. The levels of water and the electrolytes will proportionally stay the same. So the osmolarity itself will not change. So hyper is you're going to have an increase of the level of water and the electrolytes, and with hypo you're going to lose both. So the example of hypovolemia would be something like a blood loss. An example of hypervolemia would be the administration of excess fluids such as normal saline or lactated Ringer solution. Overhydration is going to have several possibilities here. Remember, this is going to be an increase in water content, but the content of the electrolytes will not increase, so the osmolality will actually go down. I remember being stumped in chemistry, having to learn the difference in osmolarity and osmolality, and I still kind of messed up there. So water toxicosis, somebody who has psychogenic polydipsia where they won't stop drinking water. This can happen after a marathon, when in fact it has happened. People have died this way. After a marathon, they drink large volumes of water very quickly. They actually had a case a while back. There was some radio contest where the DJs had promised an Xbox or something similar to a woman or to anyone who consumed the most water in a short period of time. And so the consequences is cerebral edema and death. So what happens when you drink a lot of water, you're going to have a rapid increase in water content, and so your plasma and your interstitial fluid will be very dilute. And what happens, if you recall back to experiments with the egg and water moving across the membrane, if you put a cell in a very dilute solution, water is going to move inside the cell. And the most sensitive area of the body to that is going to be the brain. So this is going to be a cerebral edema problem. So this can happen if somebody has given the wrong type of intravenous fluids, such as a D5W or anything too dilute. That's why it's much safer to err on the side of caution and use something that's going to be isotonic. You never want to do a hypotonic solution unless there's an absolute medical call for it. There will be some endocrine diseases such as diabetes insipidus. We'll discuss that when we talk about the endocrine system. So the body is making too much ADH, and so basically retaining too much water at the level of the kidneys. Congestive heart failure, chronic renal failure, cirrhosis of the liver, all of those things can result in overhydration because you're going to be having a decrease in the amount of plasma proteins. So hyponatremia, this would be a decrease in the amount of sodium. And so, of course, that's going to, again, cause your body, your plasma, and your interstitial fluid to be very dilute. Now let's look at the term edema. The definition of edema is an accumulation of fluid in the interstitial space. And it can be a localized thing, such as in your arm or your leg or a finger, or it can be all over the body. It can even be an internal condition where you have fluid around your lungs, in the lungs, inside the peritoneal cavity. So you can break it down into several different ways that edema can result. And the first one would be anything that's going to cause a decrease in the blood colloid osmotic pressure. Now, of course, the most common thing, the first thing that comes to mind, is going to be the loss of the ability to produce plasma proteins, such as a cirrhotic liver or diseased liver. So what's going to happen when you've got fluid that moves all over the body? you're going to be decreasing the amount of volume for the blood, and so consequently you're decreasing the blood pressure also. This is going to end up potentially resulting in an increase in release of things like renin, angiotensin, and aldosterone, so you're going to make the cycle of retaining fluid even worse. Another cause of edema would be increased hydrostatic pressure, and the most classic example of this would be high blood pressure or hypertension. So again, remember that we're talking about a balance between blood colloid osmotic pressure and hydrostatic pressure, and so when one of these is off, it's going to affect the amount of fluid movement across the blood vessels and across the cell membranes. So the third reason would be damage to the capillaries. So anything that's going to increase the permeability, it can be a bruise in a localized region, it can be any sort of inflammatory process, you've got some sort of toxicity going on, and you're leaking proteins through those vessel walls, and consequently fluid is following. So remember the classic signs of inflammation. We talked about rumor, tumor, calor, and dolor, and the tumor part of that was swelling. And then finally, anything that's going to block lymphatic pathways. So we talked about this earlier, and here is another photo of somebody dealing with elephantiasis, the condition of microflaria in the blood. So most common thing we think about when we talk about lymphatic blockage would be an example of a woman having breast removed from breast cancer, and then they remove the sentinel lymph nodes from her armpits, and then you're going to end up with arms that are going to be chronically swollen on that side. So let's take a closer look at the electrolytes now, and remember our terminology from earlier chapters. You have an atom, and then you remove or add an electron, it becomes an ion. If you remove an electron, you've taken away something negative, so it's going to be positive now, and that's going to be referred to as a cation. If you add an electron, it's an anion, because that's going to have a negative charge. So in the extracellular fluid, the dominant cation is always going to be sodium. Inside the cell, in the cytoplasm, you will see that it's much less. You've got about 140 milliequivalents per liter in the ECF and about 10 in the cytoplasm. So when you flip that in the cytoplasm, your potassium is going to be very high. So if you look at this, 160. But then in the serum and the ECF, you're going to be looking at 4.5 to 5.5. So it's pretty much an opposite there. So here's a couple of definitions you should know. For sodium, again, Latin is natrium. So hypernatremia would be the condition of having too high of a level of sodium in your serum. And the number one cause of that would simply be dehydration. Hyponatremia, then, of course, would simply be not enough sodium. And you actually see that a lot in especially elderly patients, and I've yet to see a physician pay too much attention to it. So I have had some oncology nurses say that they see it a lot in cancer patients, but there's not a whole lot of attention that usually gets paid to the hyponatremic condition, unless it's extreme. Potassium has a much more narrow, it's more critical homeostatic range, 4.5 to 5.5, and imbalances of it will be much more critical than what you'll see with the sodium. Hyperkalemia, or excess potassium, is associated with everything from muscle cramps to diarrhea to changes in the rhythm of the heart and even cardiac arrest. So hypokalemia is associated with profound weakness, cardiac dysrhythmias, and eventually respiratory failure. There are actually cases of murder that have been prosecuted when someone has injected a patient with excessive potassium levels. On a superficial glance, it might simply look at like a heart attack, but then on post-op, on post-mortem, you'll actually see the elevated potassium, and not finding a pathologic reason for it. Then the next step would be look to see if it was iatrogenic or induced by injection. We've talked about calcium a good bit before, and you know that this is the most abundant mineral that you've got, and the vast majority of this will be found in your skeletal system. And one of the reasons we keep so much of it stored is because it's so critical for your muscles and your nerves to function. Remember that your neuromuscular junctions, when you have your synaptic terminal, when you have an action potential that's arriving, you're going to have calcium ions that are taken into that terminal, and only that will trigger the release of the neurotransmitters from the synaptic vesicles. So you'll see calcium acting as cofactors in the electron transport system. You'll see it involved in the endocrine system as well as simply blood clotting. Remember that calcium is going to be increased in your serum levels by release of the parathyroid hormone and by calcitriol. Parathyroid hormone will activate osteoclast and cause breakdown of bone tissue, which will release calcium from the skeleton into the circulation. And calcitriol, remember, that's going to be produced at the level of the kidney using vitamin D, and that's going to cause the small intestine to absorb more calcium and phosphorus from your small intestine. So this is going to bring back more of your dietary calcium. On the flip side of that, calcium will be decreased in your circulation and your serum levels by the hormone calcitonin, and remember that is released by your thyroid gland. So cases of hypercalcemia, they're not seen that often, but you can see it in hyperparathyroidism. You can see it in certain types of cancer causing pseudo-hyperparathyroidism, and then if somebody is simply taking too much in their diet. So that's pretty hard to do, though. Hypocalcemia is a little bit more common, and this would be primarily from dietary insufficiency. Chronic renal failure might also be an example of something that would cause that, because if your kidneys aren't functioning, then you're simply not going to be able to absorb it as much as you should from your diet due to the lack of calcitriol. I'm sure you haven't heard as much about magnesium, but about 60% of that in your body is going to be in your skeleton. You'll also find it in the cytoplasm. It's important because it's going to be a cofactor in oxidative phosphorylation of the electron transport system. So I'll give you an example of how this relates to energy production. I remember in the Deep South, there would be a condition in young cattle. People would go out and buy young cattle and bring them in and put them on a wintertime pasture filled with a type of grass known as ryegrass. Ryegrass is very fast growing. It's full of a lot of water content and is very lush and green in the wintertime. So therefore, again, these cattle would come from situations where they were not exposed to it, and then they got dumped suddenly into this big field of this lush green grass. And I don't know exactly what the mechanism was, but they would eat it and experience an immediate profound drop in their serum magnesium levels, and they would go into an immediate flaccid paralysis. And it was actually called grass tetany, or grass tetanus would it be of what they're trying to say, but grass tetany would be the local colloquialism down south. And it was treated by intravenous infusions of solutions that would contain magnesium. And as soon as the IV fluid went to work, they would hop up and trot off. So that always stuck in my mind as far as the importance of proper magnesium levels when it comes to energy production. Phosphates are also going to be stored in the skeleton, and these are important because, again, your body's energy source is adenosine triphosphate. So without the phosphates, you're not going to be able to store and maintain energy. So this is going to be regulated again by calcitriol, and it's also reabsorbed at the level of the proximal convoluted tubules of the kidney. It actually works in conjunction as far as absorption with calcium. And so you will see cases of if somebody's taking pure calcium, which you really can't get it, but if you're overdosing on pure calcium, your phosphate level will get extremely low. And on the flip side, if you were taking a lot of pure phosphates, then your calcium levels will be really low. So you will actually find in nutrition there's a very critical ratio between a lot of linked minerals and vitamins, and for example, vitamin E and selenium and that sort of thing. But with calcium and phosphate, it's a 1.2 to 1 ratio. and it's impossible for you to walk into a pharmacy and buy pure calcium. If you look at the label, it's going to be calcium, it's going to be phosphate, and it's also going to have a level of vitamin D that's been added so you can absorb what you're taking. So for years and years, they have pushed calcium supplements on middle-aged women to try to treat or avoid osteoporosis. Now they're coming to the realization that it really has no effect on osteoporosis, and that it actually increases the problems with kidney stones and atherosclerosis, or calcification plaques in the arteries. We'll mention chloride here, but there's not a whole lot that it's going to be doing besides following the positive ions around. But the most abundant anion that you have in the plasma is going to be chloride. You'll consume this when you eat table salt through the GI tract, and then you lose in the urine and sweat, basically. There are conditions, in fact, cystic fibrosis is one of the things that's characteristic about it, is that the person's skin will be very, very salty. And so when the children that are diagnosed with that will notice that when they kiss their child on the forehead, it will taste very salty. And that's actually because cystic fibrosis has to do with glandular issues, and in this case the sweat glands are not properly regulating the amount of salt produced. Well, if you haven't had a break, now's a good time to take it, because we're going to switch gears and spend the rest of the chapter talking about acid-base. So I haven't had you memorize many numbers, but this is a number you should know, and that is that normal human blood pH is 7.35 to 7.45. So it's going to be on the alkalotic side of the pH scale, and you'll actually see that the venous blood is going to be more acidic than arterial blood because of the carbonic acid, and that's going to be due to the increase in carbon dioxide that you'll find in systemic venous blood. Now you may have said, well, why is blood on the higher side? And one of the reasons is that the blood is going to help buffer out the lactic acid that is made, for example, in various metabolic processes such as glycolysis. And also your cells, as they make energy, they're producing carbon dioxide and water as a byproduct, and those things will form a metabolic acid. So your blood pH is going to be on the high side of that to help counteract that. We talked about the pH scale in earlier chapters. Now let's look at it on a biological basis. So we're going to only be using the 0 to 14 scale. You do have super acids and super bases. Those are existing basically in laboratory settings. What we're going to be looking at is going to be things that are in this range around here. So remember we talked about 7 being neutral. This time our neutral is going to be shifted down a little bit. It's going to be 7.35 to 7.45. As a reminder, what we're talking about when we talk about acids can be simply thought of as hydrogen ions. Remember that when we have a hydrogen atom, you have the nucleus, which is simply a proton, and then you've got one little electron out here. So in body fluids, what's going to happen is you're going to give up the electron, and so you're simply left with this little proton, and that is going to be our hydrogen ion. Acids and bases can be toxic if they move away from their normal homeostatic range. And so the excessive amounts will have to be buffered. Remember, to buffer something is to simply neutralize it. And you will get rid of excessive acid or excessive base by 2 systems, the kidneys or the lungs. So basically, if you're going to neutralize an acid, you would absorb the extra hydrogen to neutralize it. And if you're going to neutralize something that's too alkaline or too basic, you're going to give a hydrogen ion to that substance. Don't worry about this chart too much if you find it a little bit confusing. All it's talking about is, if you look at this top row, you're looking at where does the hydrogens come from, and you're looking at in the diet. You're also looking at body metabolism. So you will always be making, every time you use food and oxygen, you're going to be making energy, and carbon dioxide and water will be a byproduct. And carbon dioxide and water, when they combine, creates carbonic acid. So keto acids and lactic acids, those are normally not made on a tremendous amount until something is going physiologically wrong. So we have several different buffer systems that will be located inside the body. We'll talk about some of those as we go through here. And then again, your normal is going to be around 7.35 to 7.45. They simply use the mid-range of that here. And then you'll have the lungs and the kidneys to excrete what you don't want to keep. As we look at biological pH, basically there's two things that can happen. Well, three, really. You can be normal. But if you have too much acid, you can have acidosis. If you have not enough acid, you'll be alkalotic. And acidosis is going to be a lot more common and typically more fatal. Understand, these are not diseases. These are syndromes that go along with different case scenarios. For example, you might have a person with congestive heart failure whose lungs are filled with fluids, so they're not breathing well enough, and so they're retaining too much carbon dioxide, and so they're acidotic. On the flip side, you might have somebody who has been throwing up for a couple of days, and they're really getting dehydrated, and they're getting alkalotic because they're throwing up all their acid in their stomach. So we'll be talking about this as it happens, but first we're going to talk about the actual definitions of acidosis and alkalosis. So as I mentioned earlier, with buffer systems, we're going to be neutralizing an acid or a base, and a buffer doesn't cause direct excretion of hydrogen. It's simply going to tie them up, and then that product is going to be excreted. So again, you can tie up those extra acids, and you can adjust through the kidneys or the lungs. There are three major buffer systems as far as chemical buffer systems in the body, and I just want to mention these first two: protein buffers and phosphate buffers. So these are simply, again, they're going to be, you can add a hydrogen here, or you can remove it as needed. Same thing here, you can add one of these or remove it, and so that's how you would be absorbing an extra hydrogen or donating one if needed be. But the next slide we'll talk about the carbonic acid buffer system, which is the biggest system in the body. You don't have to memorize this equation. I'm getting ready to write down, but I always tell my students I feel like it's sort of the secret of how our bodies work and what everything is going on. So I'm going to talk my way through this out loud, so bear with me. So C6H12O6 is glucose. So basically our food we eat, the oxygen that we breathe in, will be transformed into carbon dioxide and H2O. So this, we also have some energy being produced as that equation says, your ATP. But these byproducts then are going to be equilibrating into H2CO3, which will equilibrate into acids and bicarb. So this equation, to me, again, kind of sums up, this is why you eat, this is why you breathe, this is what you want, and this is what you produce as a byproduct. So your body has a lot of this right here, carbonic acid. And what's happening here, if you look at this equation, if you increase this, if the carbon dioxide, let's say you're not breathing properly, and then what happens, you're going to shift it in this direction, so you can have more carbonic acid made. That's going to shift it in that direction, and so you end up making more hydrogen ions, and so you become acidotic. A lot of books will talk about the hemoglobin buffer system separately. Again, when I look at it, I'm looking at this carbonic acid, so I consider it to be pretty darn much the same thing as the carbonic acid buffer system, so I simply include that. We're not going to get into logarithmic math and Henderson-Hasselbalch. I'm going to show it to you so you can appreciate your computers when you plug something in and it spits something back out. But the Henderson-Hasselbalch equation is the way that you are going to be deriving your arterial blood gas analysis. So you can look at this by saying the pH is going to be proportional to bicarb, your HCO3, bicarb over your carbon dioxide. And so what this means is if the carbon dioxide goes up, the pH gets lower. If bicarb goes up, the pH gets higher. Remember that a high pH is alkalosis and a low pH is acidosis. So there's only two things you can be. You can be acidotic or you can be alkalotic. But also there's two reasons why each of these conditions can happen. So really you're looking at 4 different scenarios. So let's talk about analyzing arterial blood gases. Remember, this has to come from arterial blood, which is always an interesting feat. It's much easier to draw blood from a vein than it is from an artery because, number one, veins are a lot easier to penetrate. An artery is going to be more muscular and elastic and tend to move away from your needle, so it's going to require a very quick, sharp little jab. And please make sure, by the way, if you're the one doing this, that you compress that thing long enough that you don't end up with a hematoma from hell. You've been told this before, but remember that the partial pressure of carbon dioxide in the systemic arterial blood is 35 to 45 millimeters mercury. That's going to be a little bit lower than what's in the venous blood because remember the arterial blood is carrying oxygen from the lungs and it's going to be delivering or picking up the carbon dioxide in the venous side, going to be returning that to the lungs to be exhaled. So this is one number you will need to know. 35 to 45 is normal for the partial pressure of carbon dioxide. Again, we're talking systemic arteries. So as I said earlier, you're going to be looking at your pH. You're going to decide if it's going to be too high or too low. If it's too low, it's going to be acidosis. If it's too high, it's going to be alkalosis. And if it's acidosis, then you need to figure out if it's coming from a respiratory issue or if it's coming from a metabolic issue. And same thing for the alkalosis. It's either going to be a respiratory issue or it's going to be a metabolic issue. So my mind just works in a flowchart method better. So first thing you do, again, look at your pH. See if it's high or if it's low, if it's going to be acidosis or alkalosis, and then you decide exactly what is the root problem. And then the last thing you'll be determining is the opposing system trying to compensate. So if you have a lung problem, your kidneys will try to compensate, and if you have a kidney problem, the lungs will try to compensate. Anytime you have a partial pressure of carbon dioxide that's abnormal, it's going to be automatically related back to the lungs. So if you see a high level, again remember that 35 to 45 is going to be normal for carbon dioxide. So if it's above that, it's going to lower your pH, which will give you a respiratory acidosis. So if your PCO2 is too low, then it's going to be a respiratory alkalosis. So this is a pretty easy concept. What can cause an abnormal partial pressure of carbon dioxide in the arterial blood system? So it's going to be affected by changes in breathing patterns. You will breathe out more carbon dioxide than normal if you're breathing too quickly. So think about hyperventilating. You will have it increased anything that's going to decrease your respiratory rate. So let's say you've got a broken rib, so it hurts to breathe, or let's say you've got severe arthritis of the rib cage and vertebral column, you're not going to be breathing as deeply. Or you could have respiratory issues such as asthma or emphysema or pneumonia. So those things would let you not expel the CO2 into the atmosphere, so it would accumulate at an increased rate in your bloodstream. The other parameter you'll be looking at in analyzing acid-base is going to be the bicarb level. So the bicarb is actually calculated, so this will be given back to you. It's not going to be directly measured. And so just an FYI type thing, when you're treating an acid-base problem, again, you're only treating what's in the plasma. That's the only thing you see. So you're going to be actually calculating doses that will cover the entire body, not just what's in the extracellular fluid. Now, I don't care that you learn this number, but I'm just going to show it to you for a comparison because we're going to talk about metabolic acid. Respiratory acidosis is the most common syndrome that accompanies underlying problems, and this is your biggest, fastest system. So if you look at this, you're producing almost 300 liters of respiratory acid a day, which calculates into about 12 moles. So this is a huge amount of acid, and so the lungs can eliminate this very quickly in a very large amount. Compare the previous slide to metabolic acid, and if you look at this, instead of producing 12 moles of acid like you do with the respiratory side, you're only producing 1/10 of a mole. So this is going to be the side that's going to be excreted by the kidneys, and you see it's going to be handling things at a much smaller and lower scale. So metabolic acids we'll be discussing a little bit later on. It's going to include lactic acid from perhaps accumulation from excessive levels of glycolysis, pyruvic acid, same thing, and then keto acids that you'll see in an uncompensated diabetic. One of the things to look at or be the most common causes of these disorders, and so it will help if you just understand that respiratory acidosis is going to be associated with anything that's going to cause hypoventilation. So the results of hypoventilation will be hypercapnia, which is increased CO2, hypoxia, which is decreased oxygen, and then respiratory acidosis. So those three things will usually be seen together. So any sort of suffocation, near drowning, any kind of lung disease, pneumonia, again, asthma, even things like damage to the brainstem in which the respiratory centers are depressed. You'll see this with narcotics when you've got depression of the respiratory centers, Valium, etc. So anything like this is going to cause an acidosis from the respiratory side. On the flip side, it's very easy to think about respiratory alkalosis because it's pretty uncommon. So the only example of anything that I can give you that would cause respiratory alkalosis would simply be hyperventilation. That's not traditionally a big problem because if somebody's hyperventilating and they don't rebreathe to slow it down, to slow down the loss of carbon dioxide, they will eventually simply pass out, and then the brain will take over and regulate the respiratory rate, and CO2 levels will come back to normal. So with hypoventilation, you're accumulating too much CO2 in your bloodstream. With hyperventilation, you're breathing it out very quickly. So when we talk about compensation, if we have a respiratory problem, it's going to be compensated by the kidneys. And since this is a respiratory acidosis, the kidneys will try to excrete the acid ions, the hydrogen ions, to compensate for this. It's also going to resorb more bicarb ions. So again, the kidneys are trying to compensate to get rid of this respiratory acidosis. So when you look at an analysis of the blood gases, you'll see a high CO2 level, that is your respiratory acidosis, and then you'll see a high bicarb level, and that is your compensation. Just wanted to show you the difference in sensations of the respiratory acidosis and alkalosis. Things like blurred vision, lethargy, disorientation, cardiac arrhythmias for acidosis. And with alkalosis, it'll be a numbness and tingling around the face. I have only experienced the respiratory alkalosis. I've only hyperventilated once in my life, and that was a year or two ago when I put my dog to sleep, and I was very upset. I was crying, and I did start to hyperventilate, and it was interesting because I remember recognizing the tingling around my mouth. You don't need to study this chart too much, but I just kind of wanted to give you an overall picture here of symptoms that will accompany acidosis. So moving away from respiratory acidosis, let's move into the second most common syndrome, which would be metabolic acidosis. So with this, you're going to see a loss of bicarb, and the PCO2 will be normal. So if you are compensated, then the carbon dioxide level of PCO2 will actually be decreased. So again, with metabolic acidosis, you would see a low bicarb, and the PCO2 levels will either be normal or low. It would be low. Again, the lungs are trying to compensate, and so you would actually breathe a little bit faster to expel more CO2. So let's look at some causes of metabolic acidosis. First off, think about the fact that in your intestinal tract, you're creating and excreting or secreting a large amount of bicarb to compensate the acidic chyme that left the stomach. So anything that causes a really severe prolonged diarrhea, you're basically eliminating your bicarb in the stool loss. So severe diarrhea would be a cause of metabolic acidosis. So lactic acidosis, anything that's causing you to go into prolonged glycolysis. For example, let's say that you've have been running a marathon for a long time, then you'll actually be, depending on your anaerobic metabolism, a little bit more, especially if you're unfit. Let's say that you've got lung failure, something's compromising your respiratory system, and so you're not able to get rid of the CO2, you're going to actually have a high CO2 level, but because you're not getting enough oxygen for your cells to undergo the electron transport system and aerobic metabolism, you'll be stuck with a lot more anaerobic metabolism. So it is possible for you to have both a lactic and both a metabolic and a respiratory acidosis at the same time. Ketoacidosis is in a non-compensated diabetic. Also, if you have somebody that's fasting or starving for any reason, the fats will be broken down preferentially, and you'll develop an excess of the ketones and the ketone bodies in the bloodstream, and those are converted into acids for ketoacidosis. And then finally, if you have a kidney issue that you're not excreting hydrogen ions, then that can also cause them to accumulate and result in metabolic acidosis. So as I said on the last slide, your lactic acidosis is going to be happening when you don't have enough oxygen for normal aerobic respiration in the mitochondria. And so you're switching off to a higher level of anaerobic respiration, which again, remember, the main component of that is glycolysis. And what will happen is you'll get production of pyruvate, and that pyruvate is going to be converted into lactic acid, and that accumulates in the muscles and in the bloodstream. So things that can cause that, again, would be prolonged overexertion or lack of oxygen. Again, not that I expect you to memorize what's on this, I just kind of wanted to show things to you here. You'll see metabolic acidosis in association. You'll also see hyperkalemia, which is high levels of serum potassium. You'll see muscular twitching. Just like with respiratory acidosis, you'll still see the vomiting and diarrhea. One of the things you'll see is Kussmaul breathing, which is going to be basically a rapid, shallow hyperventilation in which your body is trying to compensate for the metabolic acidosis. So let's move into respiratory alkalosis, and this is going to be basically, again, hyperventilation. You've breathed off more carbon dioxide than you should. You're breathing too quickly, and the body will try to compensate this if it's going to be a long, ongoing situation by having you excrete more bicarb in the kidneys. With metabolic alkalosis, you will have a high level of bicarb, and the CO2 will be elevated because what's happening here is the bicarb is going to be increasing your pH, and so your body is going to try to compensate by increasing your respiratory acid. So you will actually breathe slower to allow the CO2 to accumulate, and again, the CO2 is going to go into carbonic acid, so there's your compensation. And again, that compensation is only going to happen if this metabolic alkalosis is an ongoing situation. A few other things you'll see associated with metabolic alkalosis. Again, severe vomiting because you're going to be throwing up your stomach acid. You will see it associated with low levels of serum potassium. And every now and then there's something called a chloride shift, which is really not a pathologic thing. But if you look at this diagram over here, you basically have the inside of the stomach, and over on this side you have your interstitial fluid. So you know that you have to make hydrochloric acid to digest your food, and so what happens is the body will take this carbonic acid, break down, remove the acid ion, and send that to the stomach, and then the remaining bicarb ion is going to be sent back into the bloodstream. And so after a large meal, you'll have a temporary metabolic alkalosis. But, again, after a big meal, you usually go sleep it off, and that's not a problem. So again, when you've got a metabolic problem, the lungs will be the ones that will be taking care of it, and they're able to typically do so pretty handily because of the size of their capacity. So again, what's going to happen if you have a metabolic acidosis, you'll end up breathing faster to try to eliminate the CO2. If you have a metabolic alkalosis, you'll see a decreased respiratory rate, and you'll accumulate CO2, which is going to increase the amount of carbonic acid to counterbalance that. And as we mentioned earlier, if you have a respiratory issue, you've got respiratory alkalosis or acidosis, then the kidneys are going to try to compensate, and they're not nearly as fast or big as the lungs are going to be able to handle. And so this is going to take a longer period of time. So the response for a respiratory acidosis is that the kidneys will secrete hydrogen ions, and they will resorb more bicarb at the proximal convoluted tubules. And if you have a respiratory alkalosis, then you'll excrete more bicarb, and you'll actually secrete less acid. So you're retaining hydrogen ions and urinating out more bicarb. We mentioned these buffer systems in the urinary system, and the two buffer systems in the kidneys would be the ammonia buffer system and the phosphate buffer system. So just as a little factoid here, if you did not have these buffer systems, you'd be producing about 1,000 liters of urine per day to be able to get rid of enough hydrogen. So that would kind of crimp our lifestyle, so this is a good thing. So the proximal convoluted tubule is where ammonia can be generated, and it's going to go, for example, from an NH3 to an NH4 and absorb that extra acid. And then you simply urinate it out. In addition to looking at bicarb as a parameter in acid-base analysis, you can use a number that is known as base excess. I don't like this term, although I will use it simply because the excess part can get a little confusing if you overthink it. So this is a number that you should learn for testing purposes. Normal base excess unit is going to be from a -2 to a +2. So if you have a base excess of, let's say, +3, that means you've got too much base. So I always tell the students in class, kind of mentally eliminate the word excess. So if you've got a base excess of -4, you're negative, so that means you don't have enough base. So that is, again, going to be a metabolic parameter. Very similar, and you can use it in conjunction with or instead of the bicarb measurement. So this can be fun, or it can be very painful, depending on your approach. So let's look about how we're going to figure out what somebody is suffering from. As I said earlier, there's only so many things that can happen. You can be acidotic, or you can be alkalotic. That's either going to be a respiratory issue or a metabolic issue. So again, there's only so many things it can be. Now, when you get into a clinical situation, you will find that some of these blood gas values will have different meanings depending on the scenarios. So I just kind of did a rapid copy paste here, but it's talking about if you've got alcohol poisoning, then if you've got a pH of 7.1, it's going to be a pretty poor prognostic indicator, whereas if you're dealing with somebody that simply dealt with a grand mal seizure, then that's not going to be that big of a deal because it's going to recuperate pretty quickly. Same thing if you've got a 7.6 because somebody is hyperventilated because of anxiety. It's not something to worry about. However, if you've got a heart patient that's on digoxin and diuretics, then it can lead to some pretty serious cardiac arrhythmias. So there's going to be a situational interpretation, but that's beyond our scope right now. Now this did not reproduce too well, but I put a copy in your course documents. This is actually the same chart that I used when I was in college. And again, my brain works with a flow chart. So look at your overall pH and see if it's high or if it's low. If it's low, then you've got acidosis. If it's high, you've got alkalosis. Pretty simple. Then the next thing you're going to be looking at is going to be your carbon dioxide level. So if the carbon dioxide level is abnormal, then you've got a respiratory acidosis. If your PCO2 is normal, then you're going to have to be looking at the metabolic component of that. So that means you've got a metabolic acidosis. Same thing on the other side. If your pH is high, look at your PCO2 and see if that's normal. If it's low, then you know it's respiratory. If it's normal or high, then it's going to be metabolic. So if your PCO2 is high with the respiratory acidosis, and then your bicarb is also high, that means that the kidneys have compensated. So same thing. So make sure you kind of understand the consequences of compensation and what that's going to do. If your acidosis is metabolic and the PCO2 is down, which normally, and if you look at that out of the situation, it would be an alkalosis, that means your lungs are trying to compensate for the metabolic acidosis. Same thing moving over to the alkalosis side again. You've got a respiratory alkalosis, then you're going to end up with an increased secretion of bicarb. So you'll actually see a low bicarb level in spite of the fact that your overall pH is acidotic. So if you have a metabolic alkalosis, then the lungs are going to try to compensate by causing you to decrease your respiratory rate. So you're going to have a high level of PCO2, even though, again, you have alkalosis. It can be confusing, but if you kind of take some time and think and work your way through this, because there's so many limited options, you can figure this out. So again, always start at the top of a problem, look at your pH, and then look at your carbon dioxide level. It can be a little bit confusing when you start talking about numbers if you don't go ahead and figure this out. So anytime you see a high PCO2, you're simply talking about a respiratory acidosis. Now, it might be compensatory if it doesn't match the overall pH, but if it does match the overall pH, then you automatically have diagnosed what the situation is. So anytime you see a high CO2, you're should be thinking about a low pH. So I told you earlier there are some numbers that you will need to know. And so if we take a step back and look at it, you know that your blood pH is going to be 7.35 to 7.45. Okay, I told you that your PCO2 should be 35 to 45. But let's flip those numbers and make it 45 to 35, and I'll explain that a little bit later. Then your bicarb, HCO3, is going to, I'm going to go ahead and use the number 22 to 26 here. And then your basic cess, I've already given you. You should know that that is going to be -2 to +2. So those are numbers that you do need to go ahead and commit to your brain and memorize this. When you're taking an exam on this, you can use a blank sheet of scratch paper. You'll need to turn that in if you're in class, or if you're online, you'll need to show me the blank paper on camera before you use it. So before you even start the test, go ahead and write this down. So the reason I wrote the CO2 the way I did is you can actually make a line down the middle and call this the acid side, and this is a base side. So if you look at this again, everything to your left is more acidic, and everything to your left, to your right, is more alkalotic. So that's the way. I did not learn to write it naturally that way, but if you go ahead and condition yourself to write that PCO2 backwards, it's going to be a little bit visually less confusing for you. When you get into doing serious acid-base analysis, then you'll be dealing with things like the anion gap, but we are not going into that at this level. And I've already talked about the base excess, and again, my brain works better if I kind of ignore this word right here, but understand that if you're below normal here, then you're going to be dealing with an acidotic situation. So anything that would be negative would be anything below the -2. So the definition of base excess is the amount of hydrogen ions that would be necessary to return the pH into a homeostatic balance. And all this is simply another way of looking at your metabolic side of the equation. So you can use this in addition to or instead of the bicarb. And make sure you know this number again, -2 to +2. If this is too high, then you've got too much base, and so you know it's an alkalosis. And because we're dealing with something that's not the CO2, we know it's metabolic. If it's below -2, then you know you don't have enough base, so you're acidotic. And again, we know that it's metabolic because we're not dealing with CO2. I'm just showing this to you as far as letting you appreciate computers. This is why I don't have you calculate using the Henderson-Hasselbalch equation. So you can see it's a little bit complicated. So again, thank goodness I will give this to you. So a base excess of +4 means you've got too much base, and so therefore it's going to be a metabolic alkalosis. So that would be the equivalent of having too much bicarb. Let's say you've got a bicarb of 32. And the flip side of that, if you've got a negative base excess, in other words, if you're below -2, that means you don't have enough base, which gives you a metabolic acidosis. That will be the equivalent of not having enough bicarb. Let's say you've got a bicarb level of 20. So you've now got to have a metabolic acidosis. Don't forget to look at the compensatory mechanisms. Again, you need to look at the overall pH and see if it matches what's happening on the alternate systems to determine if you have any compensation. I think as we go through here, that will be a little easier to understand. So I'm going to give you some scenarios, and I want to kind of walk through how I would analyze this, and then I'll give you the answer on the next slide. And when you're going through this on your own, I want you to go ahead and figure out what the answer is before you actually look at the next slide. So, and at the end, I'm going to introduce you to something called acid-base tic-tac-toe, which is something you can pick up on YouTube. A lot of the nursing programs use that, including ours. And it's pretty handy. I didn't learn it that way. It doesn't come naturally to me, but I actually kind of like it now. So let's look at this woman. And you could probably figure it out just from the little pictures I give you here, but look at your pH. Is it high or is it low? Well, we know that it's low, so we have an acidosis. So you look at your PCO2 next. It is 60, and we know that it's high, so we know that we have a respiratory acidosis. So now we look at the standard base excess. It is smack in the middle of normal. The bicarb level is normal, so we know there's no compensation going on here. So let's look at the next slide and see if we are correct. So the only way to really become accomplished at this is practicing. I've had nursing students later tell me that they were very grateful for having to slog through this in this level of their education. So again, it's one of those things, if you don't overthink it, you can pick it up pretty easily. Okay, let's look at this guy. He's obviously having some problems breathing here. His pH is actually normal. So he's got a normal pH, even though it's on the low side, so his pH is normal. His PCO2 is high, so you've got a respiratory acidosis, and your base excess is very high, so he's got a metabolic compensation. So what's happened is you've got somebody who would have been very acidotic because of a lung problem, but their kidneys have compensated, and so it's brought the overall pH back in the normal range. So earlier, if you recall, I said write down 7.35 to 7.45 as your pH, and then I said your PCO2 is going to be 45 to 35. Your base excess is going to be -2 to +2, and then your bicarb, let's go with 22 to 26. A lot of references will actually use numbers like 21 or 28, and so I kind of, if I give you a problem with an abnormal bicarb, it's going to be marked enough that you're not going to be confused because of the references you used. So again, if we divide through that, you'll see that 7.35 is on the respiratory, as is on the acidotic side of the equation. You'll see that the CO2 is on the acidotic side of the equation. You will see the base excess is over here on the alkalotic side of the equation. But since the overall pH change is acidotic and the respiratory component is acidotic, we know that's the primary problem. So again, it's pretty easy to think about the fact if you look at 7.35 to 7.4 to 7.45, you can kind of see this is the acidotic region, and then this will be the alkalotic side. So when somebody is compensated all the way back to normal, see which side of normal they belong on. So again, here is your summary of that problem. Once again, we have a respiratory issue going on, and you can look at the pH, and the pH is acid. And the PCO2 again is high, and so we are having a respiratory acidosis. And then you look at the base excess, and you also have an acidotic component on the metabolic side. So you have both a metabolic and a respiratory acidosis. So this poor guy is having a double whammy here. So again, as I mentioned earlier, he can't breathe, so he's not getting enough oxygen, so his cells are using anaerobic metabolism. He's accumulating pruvates and lactic acid, so that gives you the metabolic component. And then he can't exhale enough CO2, which is giving you the respiratory component. And here's your summary for that one. And you're welcome for this picture. So let's look at this case. We've got a pH, which is acid. We've got a PCO2, which is actually going to be low. So this is going to be a respiratory alkalosis. So let's put respiratory alk. And then you look at your standard base excess, and you'll see it's very low, and your bicarb is low. So you've got a metabolic acidosis. So remember, standard base excess, anything below -2 means you don't have enough base. So since the overall pH matches the metabolic acidosis, we know that's the primary issue here. So we know that respiratory system, the alkalosis caused by breathing too fast, is simply trying to compensate. So you have a metabolic acidosis with a compensating respiratory alkalosis. So I'll be giving you some case scenarios on the exams and expect you to figure out the pH status, and then also try to figure out where it's coming from, and then also figuring out how it is compensated, or if it is compensated. So I'm going to add a few slides through here and walk you through the acid-base tic-tac-toe. Okay, so again, go to YouTube and do a search for acid-base tic-tac-toe, and there are several on there that are pretty good. I think I've posted you some links, hopefully, in that chapter, because I do like the guys better than I do the woman that has some videos on there. But basically what they're doing is you make your tic-tac-toe, and then you put your parameters at the top. You put pH, then you put carbon dioxide for the respiratory, And then you can use either base excess or the bicarb for the metabolic component. We'll use bicarb in this case. So your pH is acid. Your PCO2 is high, so it is also acid. And then your bicarb is high, so it's actually alkalotic. So your tic-tac-toe would be right here. So you know you've got a respiratory acidosis with a compensatory metabolic alkalosis. So again, first thing you do, make sure you write down your normal parameters. pH 7.35 to 7.45. Your PCO2, well, that didn't come out right. Let me fix that. Your PCO2, if my stylus will cooperate with me, 45 to 35. We're going to write that down backwards. Your bicarb is the HCO3, and we're going to say 22 to 26. And then your base excess, in case we want to use that one, we -2 to +2. So we know that everything on this side is alkaline. And then everything on this side is acid. So all you have to do is look at this and say, okay, my pH was below this, so we know it's acid. My PCO2 was above this, we know it's acid. And my bicarb was above that, so you know it's alkalotic. But since the overall pH matched the respiratory component, then we know that it's a respiratory acidosis. So let's look at this one, and we'll draw the tic-tac-toe grid, and let's do pH. I'm going to write in here respiratory, and then I'm going to write here metabolic. So, because I want you to be able to think about this from a different angle. So our pH is actually normal, because again, 7.35 to 7.45, you are normal. The PCO2 is high, so we know that it's acid. And then you look at the base excess, it's also high, so you know that is going to be metabolic. So you kind of really don't have a match here. So you have to kind of figure out, again, think about your pH. Your normal is 7.35 to 7.45. But let's go ahead and do 7.4. And then we'll go back and do 7.45. So this is your range for pH. If you look at this, your pH is actually in this part. So that's the more acidic side of normal. So that's 7.37 here. So this is on the acid side. Our respiratory is also on the acid side. So what's happened is you've got a respiratory issue that's given you a respiratory acidosis, but it is fully compensated by the metabolic component. So you have a fully compensated respiratory acidosis because the metabolic aspect was able to fix it. So if you have something that's partially compensated, then the pH will not be in the normal range. If you have something that's fully compensated, the pH has been returned to normal, but because when you look at the CO2 and the bicarb levels, you know that's not normal, then you know it's fully compensated. So again, practice makes perfect. So do some of this on your own. You can find lots of examples online. And again, go back through, use a tic-tac-toe if you like, do the little problems that I gave you, and make sure you can see how that came about.